The highest rate of implant failure occurs in type 4 bone. Bone quality is categorized according to its cortical plane thickness and cancellous trabecular density. The thicker the cortical plate and the higher the cancellous density, the higher the quality of the bone in terms of implant stability and support. Type 1 bone is the best quality and most suitable for retention of implants. Type 1 bone occurs in the anterior mandible, for example, where the bone is mostly cortical bone. Type 2 bone is a thick layer of cortical bone, and the cancellous bone core is most dense. Type 3 is composed of a thin layer of cortical bone surrounding a dense core of cancellous bone, and type 4 is characteristic of posterior maxilla and has a typical thin cortical plate and low density cancellous bone core, and thus is the least well suited for promoting osseointegration and supporting occlusal loads. The risk of implant failure is higher than normal in cigarette smokers, poor quality bone, the maxilla than in the mandible, and individuals with uncontrolled diabetes. Risk factors. Give me one second. Risk factors for implant failure or complications include metabolic disease that can influence systemic healing. Uncontrolled diabetes is one of the conditions, as are bone metabolic diseases, history of head and neck radiation therapy, and immunosuppressive medications. Implant failures are recognized to be more frequent in smokers. Failure rates are highest where the bone is of the poorest quality, such as D4 bone in the posterior maxilla. In patients with normal bone, normal healing capabilities, one should anticipate dental implant success rates of, again, in patients with normal bone and normal healing capacities, one should anticipate dental implant success rates of 90 to 95%. In patients with normal healing capabilities, especially good bone healing capabilities, and sufficient bone of good quality, implant success rates are often quoted in a range of 90 to 95%. Diminished healing capacity would possibly be encountered in patients with uncontrolled or poorly controlled diabetes mellitus, immunocompromised states, radiation treatments, and chemotherapy. Patients with well-controlled diabetes do not have compromised implants outcomes. Patients with a diminished capacity for fighting infection could be expected to experience problems with oral surgical procedures, including implants. Smoking is not a contradiction for the placement of dental implants. However, failure rates are higher in smokers. The failure rate is related to the amount of smoking on a daily basis and the pack-a-year history of the patient. Remember, implants should not be considered for children who are still experiencing growth. Note: implant failures are generally considered to be early, meaning soon after surgical placement and before prosthetic loading, or late, meaning after an extended period of time following placement of the prosthetic restoration on the implant. Early failures are related to surgical trauma and implant instability at the time of the placement. Later failures are most often related to microbial plaque accumulation equivalent to periodontal disease and or to excessive occlusal forces. Periimplantal mucositis denotes inflammation of the soft tissue surrounding the implant but with no loss of bone. Periimplantitis refers to inflammation but with accompanying loss of implant supporting bone. Both conditions require treatment. The greatest aesthetic challenge for the restorative dentist occurs in the patient having the greatest aesthetic challenge for the restorative dentist occurs in the patient having a high smile line, thick periodontal biotype, low smile line, thin periodontal biotype. I think it's going to be high smile line, thin periodontal biotype. Yeah, makes sense. So, a high smile line with thin periodontal biotype, a low smile line indicates that the patient does not lift the lip upward when smiling to the extent that the gingival restorative interface can be seen by the observer. Consequently, aesthetic compromises may be more acceptable to the patient because they are not routinely visible. A thick periodontal biotype indicates that the patient has thicker, denser gingiva with a less pronounced scallop. This type of tissue is more resistant to recession caused by restorative procedures and materials. This type of tissue is more resistant to recession caused by restorative procedures and materials, a lower chance of show-through of the implant or abutment, and a lower chance of loss of the papillae adjacent to the implant. Abutments can be made from metal or ceramic materials. Aluminum oxide and zirconium ceramic abutments can be fabricated by CAD/CAM, computer-aided design, and computer-aided manufacture methods and mill by machine. Ceramic abutments may be more subject to fracture than titanium or other material abutments under heavy occlusal load. Implants are useful for orthodontic anchorage because implants do not move in response to orthodontic forces, do not have periodontal ligament, can be placed and later removed, can be located to gain force advantage, or all of the above. Probably all of the above. Yes. So, implants Implants do not move in response to orthodontic forces because they do not have a periodontal ligament. Thus, bone cannot be resorbed and replaced at the bone implant interface, such as round teeth, to make implant movement possible. Certain types of implants can conveniently be placed for anchorage on a temporary basis as they and then removed later following completion of the orthodontic treatment. The periodontal ligament is responsible for proprioception around the natural teeth. The lack of the periodontal ligament around implants results in a much reduced tactile sensation of where the implants are in relation to the opposing occlusion. There is a phenomenon that develops with time called osteoperception, which gives the patient a certain amount of tactile sensation regarding the implants in the bone. Assessment of the potential implantation should include direct palpation of the bony ridges, yes. Determination of any limitations of mouth opening, yes. Cross-sectional imaging, yes, because we need to assess the width of the bone. So I think it's all of the above. Yes, all the above. The assessment of the prospective implant patient should include direct palpation of the bone contours in the area of the planned implant to judge for adequate bone volume. It is particularly important that the lingual contours of the mandible and any possible concavities such as a submandibular fossa be explored since surgical encroachment of such areas can lead to life-threatening complications for the patient. Cross-sectional imaging is not absolutely required, but is far superior to two-dimensional radiography and will be considered the standard of care in many locations. Defense of the omission of cross-sectional imaging analysis would seem difficult in the event of a surgical complication. Again, defense on the omission of a cross-sectional imaging analysis would seem difficult in the event of a surgical complication. Limitations of any mouth opening ability on the part of the patient can produce placement of an implant due to inability to accommodate handpiece and drills. I thought I meant to say preclude the patient placement of implant. The anterior loop is descriptive of the circular course of the internal maxillary artery, the maxillary sinus extension toward the canine tooth, course of inferior alveolar nerve anterior to the mental foramen, necessity for angled abutments. I do not know the answer. So, the anterior loop is the course of the inferior alveolar nerve anterior to the mental foramen. When treatment planning mandibular implant locations, the possibility that the inferior alveolar nerve courses anterior to the mental foramen by as much as 4 mm before looping back distally to exit through the mental foramen must be considered. If imaging data does not clearly identify the canal of the inferior alveolar nerve as it approaches the mental foramen, the implant locations should be planned to be at least 5 millimeters or more anterior to that foramen. The inferior alveolar nerve also courses from lingual to buccal as it moves anteriorly. When planning implant position, the osteotomy preparation should be planned to end at a minimum of 2 millimeters vertical away from the mandibular canal and 2 millimeters away from any other vital structure. 2 millimeters is the key measurement. At the conclusion of surgical placement of titanium implant, complete soft tissue coverage of the implant is required for successful osseointegration to occur. Is this true or false? Again, at the conclusion of surgical placement of a titanium implant, complete soft tissue coverage of the implant is required for successful osseointegration to occur. Not true. This concept was adhered to in the early techniques for surgical placement of two-piece or two-stage or submerged implant systems. Two-piece systems typically involve initial osseous placement of the implant and coverage with primary closure of the gingival flaps. Again, two-piece systems this concept was adhered to in the early techniques of surgical placement of two-piece or two-stage of submerged implant systems. Two-piece systems typically involve initial osseous placement of the implant and coverage with primary closure of the gingival flaps. Current surgical placement techniques for two-piece systems also include leaving the attached abutment exposed to the oral cavity at the time of implant placement. One-piece systems, also called one-stage or submerged systems, are typically placed with the implant exposed to the oral cavity, also called transgingival placement. A radiographic stent or guide identifies proposed implant sites in the radiograph, positions opaque markers in the radiograph, correlates information on the radiograph's cast and wax up, can help identify distortions in the radiograph. Where should the healing abutment be placed at the stage 2 surgery for a two-piece implant system? Again, where should the healing abutment be placed at the stage 2? Approximately 1 to 2 millimeters taller than the height of the tissue, out of occlusion, radiographically confirmed as seated, designed to shape or mold the tissue. Okay, I would say out of occlusion, obviously, radiographically confirmed as seated, yes. Designed to shape or mold the tissue, yes. And higher, Yeah, it's all of them. I wasn't sure about the 1 to 2 millimeters. I was gonna say a little more, in case it grew over it. The tissue grew over the abutment, but it is possible for an implant that was surgically placed with primary stability and given adequate time to osseointegrate that can subsequently be found to rotate in the osteotomy at the time of the second stage surgery. Again, it is possible for an implant that was surgically placed with primary stability and given adequate time to osseointegrate can subsequently be found to rotate in the osteotomy at the time of the second stage surgery. This rotation is sometimes detected when the healing abutment is attached to or torqued into the implant. Although mobility of an implant is considered a sign of implant failure in certain or other circumstances, the rotation of the implant at second stage surgery may possibly be overcome by replacing the cover screw, covering the implant with soft tissue, and allowing the site to heal for an additional 3 months. The implant is taken completely out of function for this time. We're almost done with the implant section. We have 9 questions more according to this. 9 more questions. 10 with this one. Cross-sectional imaging is produced by all the following except one. Which one is the exception? Cone beam computed tomography, panoramic radiography, that's the exception. Yes. Panoramic radiography cannot do cross-sectional imaging. Cone beam computed tomography, CBCT, is a three-dimensional imaging modality that produces a digital data that can be reformatted to produce multiple cross-section slices and other views of the jaws. CBCT exposes the patient to a relatively low dose of radiation when compared to medical-grade CTs. Conventional linear tomography utilizes a radiation source and an X-ray film which rotate in tandem around the single point to produce a cross-sectional view left over after everything else is blurred out in the image. Image quality of linear tomography is of significant lower quality than CBCT. Again, image quality or of linear tomography is of significantly lower quality than CBCT, than CAT scans. Okay, so advantages and disadvantages of various radiographic projections. Periapical and occlusal radiography has the advantages that it has high resolution to detail, easy acquisition, low exposure, and inexpensive. The disadvantages: unpredictable magnification, small image area, 2D representation of the anatomy. That's PAs and occlusal radiographies. Now, panoramic radiographies, they're easy to acquire, images hold rich, low exposure, and inexpensive. The disadvantages are unpredictable magnification, 2D representation of anatomy, and not detailed. Number 3, it's a lateral cephalometric radiography. It's easy to acquire, predictable magnification, low exposure, and inexpensive. The disadvantages are that are limited use, limited use in area of midline, and are a 2D representation of the anatomy. Conventional tomography has the advantages that it's a 3D representation, it's predictable magnification, sufficient detail, low exposure, and image areas of interest only. These advantages requires special equipment for evaluation of multiple sites can be a lengthy procedure because patient must be repositioned for each site. Blurring of image may occur depending on adjacent structures and is expensive. Computer tomography, which is a CT or a CAT scan, it's 3D representation, predictable magnification, sufficient detail, digital format, images whole arch. Disadvantages requires special equipment, expensive high exposure dose, and images whole arch. And the last one, the CBCT, cone beam computer tomography, 3D, predictable magnification, sufficient detail, digital format, images whole arch, low dose, and requires special equipment, expensive images whole arch. The clinical examination of osseointegrated dental plates should include let's do a pause right there.